Hello and welcome to this month's Simon Says Expert Series. I am Jodi Skiles and I specialize in pediatric hematology oncology. While I work to bring new breakthrough therapies like CAR T cell therapy to children and young adults with cancer as a stem cell transplant physician and researcher. I'm the medical director of both the adolescent and young adult oncology program at the Riley Hospital for Children, and I am also the director of the Pediatric Stem Cell Transplant and Immunotherapy Program. I am thrilled today to be joined by Amanda Saraf, who is joining us. Dr. Saraf completed her pediatric hematology oncology fellowship training at Nationwide Children's Hospital before being recruited to Riley to help grow the Fertility Preservation Program in 2018. She specializes in the treatment of pediatric leukemia and now also serves as the medical director of the Fertility Preservation Program. Amanda?
Thank you so much, Jodi. I'm looking forward to discussing a topic that we're both really passionate about.
So infertility is a well-known side effect of many cancer therapies and one that many cancer survivors cite as a source of significant distress once the cancer therapy is completed. We both have an interest in this field and look forward to sharing more with all of you. So let's kick it off with just a really general discussion about what fertility is and why does it matter in the setting of a new cancer diagnosis.
That's an excellent question. So simply put, fertility is the natural ability to conceive a child. And it's really important in the setting of a new cancer diagnosis because chemotherapy and other treatments used to treat cancer can actually impact fertility.
And can you tell us, Amanda, are all therapies created equal when it comes to the impact on fertility?
They are not. So we'll just briefly talk about different cancer-directed therapies, which broadly includes chemotherapy, radiation, and surgery. So when it comes to chemotherapy, there are specific classes of chemotherapy agents that are known to be gonadotoxic or specifically toxic in regards to fertility. So one class includes alkylators. So these are medications like cyclophosphamide. And then we also think about heavy metals. So that includes things like carboplatin, cisplatin. And those are specifically the agents that we look at that when we're calculating a patient's fertility risk. We've also learned over time that these agents work in a dose-dependent manner, meaning the bigger the dose of these chemotherapy agents you need, the higher the risk to your fertility. And then when we think about radiation therapy, so if a patient is receiving radiation either to the brain, the ovaries, or the testicles, depending on the dose of radiation, this can also cause a fertility impact. And as you might imagine, if there are surgical procedures that would impact, again, the brain, the ovaries, or the testicles, that can certainly also impact fertility.
And Dr. Saraf, can you explain why the brain is important when the gonads are nowhere near the brain?
Yeah, excellent question. So the brain is responsible for regulating all of our hormones, and those hormones talk to our ovaries and our testicles and ensure proper function. So if we have radiation or a surgical procedure that impacts the area of the brain that controls the hormones, our body is not going to be able to sort of regulate our fertility appropriately.
Perfect. So when we think about the impact of all of these therapies on our fertility, can you share a little bit about, are the impacts on fertility different for men and women?
Yes, they are different. So we have found that our male patients are more sensitive to these gonadotoxic therapies, meaning they cannot tolerate as high of a dose before starting to see impact on fertility. And this is really just because the testicular tissue and the cells that produce sperm are very sensitive to chemotherapy.
Perfect. And then as an extension of that, I guess the next question is, does it matter at what age you receive these therapies as to what kind of impact there is on fertility?
Yeah, so in terms of our male patients, it does not matter. However, when we think about our female patients, age is important. And I'll talk about two different scenarios in which age plays a role. So first, for our very young female patients that are prepubertal, so from birth all the way up until the teenage years when you reach puberty, this age is a little bit more of a protective state when it comes to fertility risk. And essentially, the ovaries themselves are not, there's not much going on. There's not a lot of metabolic activity. So when a patient receives chemotherapy in that age range, the thought is that their ovaries are, there's not as much blood flow directed to that area. They're likely just exposed to less chemotherapy. And so girls in that age range can tolerate a higher dose of chemotherapy before experiencing issues with fertility. So that's the first scenario. And then the other important time frame to discuss is women that are in their 30s and beyond. And I'll tell you a bit about, why this is important. So when a girl is born, she's born with all of the eggs that she's ever going to have. And over the course of her lifetime, typically beginning in about 30s, mid 30s, we see a natural decline in the number of eggs. And this continues on until women reach menopause and are no longer able to have babies. So women that actually receive their treatment around this time in their mid 30s and beyond, that natural decline in eggs can be accelerated by chemotherapy and other treatments. And so if you have a patient who is in this age range and has not yet met their parenthood goals, it's really important to talk about fertility.
Great. So if every patient that is going to be receiving these therapies is impacted, what can we do about it?
Yeah, that's a great question. So we'll dive into the fertility preservation options a little bit, and we'll talk about men first. So if you have a male patient who is a teenager and has gone through puberty or older, an adult patient, we can offer sperm banking. And that's a really simple process. We have our patients collect a sperm sample, and then that sample is actually cryopreserved or frozen for use in the future. There are a variety of ways to use it, depending on the sample and the quantity of sperm. And so we won't get into all of the details of that quite yet. Beyond that, we have patients that can't produce a sperm sample for a variety of reasons. So sometimes with our adult patients, they may come in too sick to actually produce a sample. They may be biologically old enough to have sperm present, but with a new cancer diagnosis, may be too sick. And so in that case, we actually have some surgical or operative options to consider for these patients. One thing that we can offer is called testicular sperm extraction. And it's essentially a surgical procedure in which sperm is extracted from the testicles and again, cryopreserved in the same way. The other option, if we have a male patient who is unable to produce a specimen manually, we have an option that's called EEJ, and that stands for electroejaculation. This is a process that's also done in the operating room under sedation, and essentially uses a probe with an electrical current to stimulate the ejaculatory response, and a sample is collected that way. And then again, these samples will be frozen for use later. The other option that I want to talk about is sometimes we have patients that are too young to collect a sperm sample. So these are our youngest pediatric patients from birth up until the time they reach puberty. Prior to puberty, boys do not have mature sperm present. So those prior options are not available to them. We do have one experimental option that I'll tell you about. It's called testicular tissue cryopreservation. And essentially what that means is that we take a small wedge of the testicle, remove it surgically, and then that piece of tissue is frozen for use later. The procedure itself is very simple, but it's very important to note that this protocol is entirely experimental, because the technology to use this tissue in the future to conceive a child is not yet available. There are many research studies going on to look into the best way to use this tissue, but has not yet been done outside of animal models. And so this is an option that we offer to our families of young children that will receive therapy that will very likely make them infertile. So they'll be at high risk for infertility, and so we would consider offering this as an option.
And is that experimental option, Dr. Saraf, is that available to any child who is receiving chemotherapy?
Great question. So not to any child. So there are some requirements. Again, because it's experimental, the patients that are offered this procedure must be at high risk for infertility based on their treatment protocol. So either the chemotherapy or the radiation that they're going to get during treatment. And then they must also have 2 testicles present in order to proceed with this process.
Perfect. So that covers the male side of things. Let's turn our attention now to the female side of things.
Yeah.
What options are available for females?
Yeah. So for our pubertal females, our young adults and adult women, we can offer egg harvest. So this is a process in which a woman would receive hormonal stimulation. And the purpose of that is to encourage her body to release more than just the single egg that is typically released each month. And this hormonal stimulation process can take up to 2 weeks. During that time, labs are monitored closely, and she's following closely with a fertility doctor. And when the body is prepared and ready, then these patients will undergo egg harvest. And so the eggs are removed, and then they will be frozen, similar to what we do with the other tissues as well. So that's our kind of gold standard option for our pubertal women. Again, we do have an option for our young girls who have not yet gone through puberty and do not have mature eggs to collect. So again, this is offered from birth onward. And this is called ovarian tissue cryopreservation. So similar to the male option that we just discussed, an ovary is removed surgically and again cryopreserved for future use. It still carries an experimental classification for our young patients, but this has also been used in adult women for a variety of reasons, and there have been live births using this option. So to date, there's over 100 live-born babies using this option. And I'll tell you a little bit about the process that we have available to use currently. So when a woman is ready for childbearing, this cryopreserved ovary can be used at that time. And often strips of the ovarian tissue are used, and it can actually be placed back into the body. And the location that it's placed depends a little bit on the woman's health and what other surgical procedures or radiation therapy she may have gone through. Ideally, it's placed actually back into the pelvis, right where it came from in its anatomic position. And then the woman's hormones traveling throughout the body will allow that tissue to mature, and mature eggs can be released. There have been cases where conception has actually occurred naturally in this model, where an egg is released and a woman conceives a child. In some cases, either, it doesn't work quite like that, or the tissue may need to be placed in an alternate location. If a woman has had many abdominal surgeries, for example, there may be scar tissue and other reasons that it's not a great idea to put it back directly where it came from. And so in those cases, strips of the ovarian tissue can be placed in other parts of the body, sometimes just under the skin and the forearm. And again, the hormones will allow that tissue to mature as well. And then eggs can be collected and used for conception of a child, usually through options like in vitro fertilization or IVF.
One question that sometimes comes up, Dr. Saraf, when we talk about these options for our young adult patients who may not have established a partner yet that they know that they want to have children with. Is it necessary actually to have a partner, or do you have to have a source of sperm in order to undergo these egg procedures?
Great question. You do not. So, as a pediatric oncologist, the majority of patients that I'm talking to about these options are young adults, teenagers that are not necessarily partnered. And so, for a process like egg harvest, after the eggs are harvested, you have the option of freezing them as is. Or if you are an adult that is partnered, you can choose to use sperm from your partner or from a sperm donor at that time to create embryos. But if that is not your current situation, then that's not required, and you can freeze just eggs.
Perfect. So one other topic of conversation that often comes up around fertility sparing procedures, and specifically, I think what most people have heard about is IVF, is that these therapies are expensive. Can you talk a little bit about the world of finances around fertility sparing procedures and what's covered and what does this roughly cost?
Yeah, yes. So, generally speaking, fertility preservation is not covered by most insurance providers. And that's not mandated in the state of Indiana that they provide coverage. We do always check with individuals' insurance plans to ensure, because every now and then there is a fertility benefit that's included. But largely, the cost for all of these procedures is out of pocket. The cost, as you can imagine, is really variable. So when we think about something like sperm banking, going and producing a sample and leaving it for analysis to make sure that there are sperm present and that you have a good quantity of sperm, that process is about $300, $400, sort of in that few $100 range. When you think about something like egg harvest, often the cost is $10,000 or greater. And that includes both the medication needed for hormonal stimulation, as well as the blood testing and ultrasounds that go along with that, and then the actual procedure of egg harvest. When we think about the two experimental protocols for our younger patients, ovarian and testicular tissue cryopreservation, the cost varies per institution that it's offered at, but typically in the $5,000 plus range. So it's a big financial ask for families. And beyond those initial procedures, if you do have tissue to store long term, there is also an annual storage fee for as long as you want to keep those tissues frozen.
And can you talk a little bit, Dr. Saraf, about are there sources of support for helping patients get past some of these financial obstacles?
Yeah, so there are some options for patients. There are a few charitable organizations like Livestrong and Verna's Purse, and they can help with some of the costs associated with this. So Livestrong can sometimes help with the cost of medications for egg harvest, and Verna's Purse often can help with the long-term storage fees that these patients will incur. Locally, there have been donors through the Riley Children's Foundation that have requested that we give back directly to patients that are undergoing some of these procedures. So that's been a wonderful help for some of our patients. But really, looking to the future, I think the key to this is going to be advocacy. So I mentioned earlier that in the state of Indiana, it is not mandated to provide insurance coverage for fertility preservation. But as of this year, across the United States, there are 16 states that have passed bills that now require insurance to provide some form of fertility coverage. That coverage does vary from state to state, and exactly what that looks like and how much is covered. But advocacy, I think, is going to be our answer here. So if anyone is listening is interested in advocacy, please reach out to our team. It's something that we would love to take on and be able to reduce this financial burden for our patients.
Outstanding. One of the things that you touched on, Dr. Saraf, is that particularly for women who are interested in undergoing fertility-sparing procedures, not only is there a significant cost barrier, there's also just the logistics of how long it takes to actually accomplish fertility-sparing procedures. Can you talk a little bit about the impact of the timing of cancer therapy relative to fertility preservation?
Absolutely. So, this is something that we think about on an individualized basis for each patient. When a patient is newly diagnosed with a cancer, the timeline to start treatment can vary significantly. So if we have a patient with an acute leukemia, for example, we're going to be starting chemotherapy in days, whereas we have some patients that may have a solid tumor diagnosis and undergoing additional workup, and they may have more on the order of weeks before their therapy starts. It just depends on the patient's specific scenario. And then again, when we think about the fertility preservation options that are offered, sperm banking is something that can be arranged and completed quickly, whereas, as you mentioned, egg harvest can take on the order of about 2 weeks. So we always discuss each patient's individual circumstance, and depending on their interest, we discuss the timeline with their primary oncology team to see if there is time to accomplish these procedures before they need to start their chemotherapy.
And would there ever be a situation where the oncologist would say a delay is not advisable?
Yeah, absolutely. So, this is again an individualized conversation that we have with each family. But there are scenarios where either, patients are having very significant symptoms, they may be having pain or shortness of breath, or their condition is progressing rapidly, and we really need to start chemotherapy urgently. And in some of those scenarios, we are not able to accomplish fertility preservation prior to starting.
So in the event that there isn't the ability to take a pause and focus on fertility prior to start of therapy, are there options for fertility preservation either in the midst of therapy or after therapy is complete?
Yeah, that's a great question. And again, it depends a little bit on the patient, on their sex and their age. So for men, typically once chemotherapy is started, we know that chemotherapy comes with other side effects. For example, your blood counts are going to drop. Well, we see a similar phenomenon with sperm count. It affects the sperm in the same way. And throughout therapy, your sperm count is going to drop, and the sperm that's present may be damaged by certain types of chemotherapy. So for pubertal men, once therapy starts, there is not a lot that we can do for fertility preservation at that time. One thing that we recommend is after a young man has finished his chemotherapy, we recommend a year or two to allow the body to really heal and recover and see what comes back in terms of sperm count. We often send these patients to have a semen analysis done so they can see exactly what their impact has been. And again, we allow a recovery period before we would recommend that. When we think about women who are pubertal, it's an interesting question. There actually might be a window of fertility available after therapy. And again, it comes back to the way that women are born with all the eggs they will ever have, and these are slowly sort of depleted throughout their lifetime. So if the ovarian reserve is not depleted once chemotherapy is over, some women may actually have a period of time or a window of natural fertility. And during that time, they could elect to harvest eggs after completion of therapy, or depending on where they are in their life and they may actually attempt to just naturally conceive a child at that point. So that's thinking about, adult or at least pubertal men and women. When we think about our prepubertal patients and the experimental procedures that I discussed, ovarian and testicular tissue cryopreservation, those procedures can be done during therapy. So there is a threshold of chemotherapy dosing for both men and women that we know will push them into the high risk range. And at that point, we know that, or we would expect that significant damage has been done to that tissue. So if a patient must start chemotherapy urgently and cannot have preservation prior, if they have not received much chemotherapy or have not met these sort of thresholds of high risk and, anticipated damage to the tissue, then we can sometimes do ovarian and testicular tissue cryopreservation during treatment.
Perfect. So let's say we have a scenario where a patient is now done with all of their cancer-directed therapy. They're moving on with their life, but they didn't have the opportunity to either preserve fertility before they started cancer therapy, or maybe they did and they're just ready to move on with their life. What should their next step be as they move forward in survivorship?
Yeah. So if you have banked any sort of tissue, the next step would be connecting with a reproductive endocrinologist or a fertility doctor to take a look at what tissue you have banked and talk about what options you have for using it. For our patients that have not had a chance to do fertility preservation prior, they should also check in with their doctor. So I mentioned earlier that for men, post-chemotherapy, they can go and have a semen analysis completed, and that will tell them, what has the impact been? Are there still sperm present or not? And that can be helpful in the next steps for family planning. And similarly for women, we don't have quite an easy way to measure fertility in women like we do with men and sending them for a semen analysis. But they can certainly have hormones checked and check in with a reproductive endocrinologist to see sort of what the state of their fertility looks like, and discuss options moving forward, whether natural conception should be attempted or assisted reproductive technologies.
And for patients, Dr. Saraf, that may have undergone therapy before fertility preservation was really a field with a hopefully standardized approach now, is there an opportunity for those patients to pursue fertility preservation? I know you touched on this a little bit, but can you talk a little bit about, I know that there are a population of patients out there that didn't ever have this conversation when therapy was starting. Can you speak a little bit to that?
Yes, you bring up a great point. We do see survivors who had their therapy before fertility preservation was commonly talked about. And now, there is a big focus on survivorship and late effects. Our program here was really formally established about 5 years ago. Prior to that, we were trying to see the patients that were at the highest risk of being infertile, and of course, addressing questions that patients had. But now, just from our experience with our survivors and learning how important this is to patients and how vital it is that we have these conversations up front, our team aims to meet with every patient and family that has a new cancer diagnosis and will receive either systemic chemotherapy, radiation, or surgery that would impact the gonads, just to talk about what their risk will be and their options will be. But you're certainly right. We are still seeing patients that were treated before this was an option. So those patients should check in with their primary oncologist and discuss whether a fertility referral would be helpful. Again, there are things that at least can be assessed to determine where we think fertility is, either for male or female patients that are in survivorship.
And is this something, Dr. Saraf? I know there's a sort of a honeymoon period after treatment is complete, where usually patients are following up with their primary oncologist, and then some patients will actually move into a formal survivorship clinic. And in survivorship clinic, typically we try really hard to bake these services into the survivorship clinic experience. But I'm curious if you can speak to, for patients that aren't in survivorship clinic, is this a topic that they need to bring up with their primary provider, or can they expect that their primary oncologist is going to cover these as part of routine care?
Yeah, I think that is really variable. I think it's absolutely reasonable to bring up to your primary provider. And sometimes this needs to be a multidisciplinary approach. Your primary oncologist will be able to speak to what therapies you've received. Your primary provider, whoever you're seeing at the time, will be able to sort of generally assess your medical condition at that time. Are you fit? Is a carrying a pregnancy safe, for example? And then sometimes we need to involve fertility experts on top of that. So again, like a reproductive endocrinologist, to sort of do some additional evaluations and see where you are.
The other thing that I would encourage patients to pay attention to, particularly for our female patients, sometimes patients after therapy, as their ovarian reserve declines, will enter into menopause at a younger age. And so that means that patients can experience menopausal symptoms, hot flashes, vaginal dryness, pain with intercourse, those types of things that sometimes can be really hard to talk about, especially if you're not mentally making the connection to, is this a result of my cancer therapy? So can you speak a little bit about premature ovarian failure and premature ovarian insufficiency?
Yeah, absolutely. So again, we talked about that sort of natural decline in the ovarian reserve, which can speed up in relation to cancer-directed therapies. And so as you're starting to see that decline, patients may not have a ton of symptoms at that stage. Patients may still have periods, which sometimes feels like a sign that fertility is okay, but periods do not always equal, normal fertility. As patients move from decreased eggs or ovarian insufficiency into the ovarian failure realm, that's when you're going to start seeing those symptoms of menopause that it's totally appropriate to bring to whomever you're seeing at that time, whether you're still plugged in with your oncologist or you're in the survivorship clinic or you have a regular OB-GYN that you can speak with. Very important to bring those things up because there are ways that we can help manage a lot of those symptoms.
Perfect. So now, as we have been talking, Dr. Saraf, there have been a number of questions that have come in. So I'm going to switch gears a little bit and switch to sort of a question and answer format, just responding to questions from the audience. So I'm going to start with the questions that we received before the start of today's Simon Says series, and then I'll transition to questions that have come in as we've been talking. So one of the first ones is, can you speak a little bit to what the success or failure rate is of fertility sparing procedures?
Yeah, that's a great question. So in terms of sperm banking and egg banking, those are considered the gold standard. When you get into the details of I saved sperm or I saved eggs prior to therapy, how likely is it that I will have a baby at the end? That's a really complicated question. And really a reproductive endocrinologist would need to meet and talk with you about exactly what your sample looks like. Do you have a normal sperm concentration? Do you have normal functioning sperm? Similarly, are the eggs healthy? How many eggs do you have? Because it's certainly, though it only takes one egg and one sperm, when thinking about reproductive technology, that is not always how it works. I have one egg available, that's not a 100% chance that you will have a live born baby in that scenario. So that's a great question. The other piece that I'll just touch on briefly is that when it comes to our experimental procedures for our prepubertal patients, families often ask that question, how likely is this procedure that I'm putting my child through, how likely is it to result in a child when they're an adult and ready for that? And unfortunately, we don't have those answers yet. We don't have enough data to be able to provide families with statistics. From the ovarian tissue cryo perspective, there have been live births, but there have not been as many young prepubertal patients who have gone back to use that tissue yet. We have had hundreds and hundreds of patients undergo this procedure, but if I'm treating a 3-year-old, it's going to be maybe 20 years before she goes back to actually attempt to use that tissue. And so we just don't have enough data from that perspective. And then, as I mentioned, for a testicular tissue cryo, it has not moved into human trial yet. And so we have no data really to share with families about how likely it is to result in the birth of a child.
And I'll just take a moment here to pause and state that each individual patient's scenario is so unique that it's hard to really give answers that will answer all of the questions. And there are certainly some very detailed questions in the chat that I think could really benefit from a conversation. So I'm going to take a moment to just share with you our contact information of our fertility preservation program. I'll mention this again at the end, but I'm going to say it once here and then we'll put it back up at the end. So the phone number for fertility preservation consultation is 317-944-0281. That's 317-944-0281. Or you can reach us by email at fertilitypreservation@iuhealth.org, fertilitypreservation@iuhealth.org. So if we are answering questions and it's not just getting to the level of detail that you feel like you really need to reach answers about your next steps, feel free to reach out to us. And there may be situations where we can help you straight away, or there may be situations where we say you really need to speak with a fertility specialist and we can help get you connected. In terms of the next question, so one of the questions is, are there special considerations for genetic causes of cancer and its impact on fertility?
Yeah, that's a great question. So if you have a known genetic cause for your cancer, or if you have a hereditary cancer predisposition in your family, that is something that you can absolutely speak to a reproductive endocrinologist about. And there may be options when you go through the fertility preservation procedures to sort of more deeply investigate that. So for example, if we have a family that carries the BRCA mutation, sometimes when embryos are created, so you've harvested eggs or you've saved a sperm sample, when those embryos are created, they can do pre-implantation genetic testing to look for very specific genetic causes of cancer that may be important in your case or passed down through your family. And so you may be able to get information about whether or not the embryos carry that change or not.
Perfect. We covered this a little bit in our discussion earlier, but once chemotherapy is started, at what point is it too late, if any, to preserve fertility?
Yeah, that's a great question too. And so again, for our male patients, once chemotherapy has really been started and you're into the process, we would not recommend attempting to save a sperm sample, again, because we expect sperm counts to drop with treatment, and also because the sperm that's present could be damaged by the chemotherapy. Similar when we think about eggs as far as once treatment starts, but as I mentioned earlier, after treatment and after recovery from treatment, some women do have a second window to consider fertility preservation. That's a great question.
Perfect. Here's a little shorter one. How long does it take eggs to recover after chemotherapy?
Yeah, that's a great question. So in women that we are not expecting to necessarily be infertile after their treatment, we do advise that they wait around 12 months to have a pregnancy. Now, I will say that things vary in each individual woman's case. And so that sort of recovery time frame allows the body to recover in many ways, but allows mature eggs to sort of recover from that process. And I will say, though, that not all women, depending on age and their life circumstances, will have a year to wait. And so if you're in that, zone, or you have questions about that, please talk to your doctor about your individual circumstance. But in general, it would be optimal to wait 6 to 12 months after treatment to allow for your body to recover.
Perfect. And then kind of on the other end of the spectrum, what risks should be kept in mind for patients who undergo egg preservation before receiving chemotherapy? Is there a waiting time after egg harvest to proceed with chemo?
Yeah, great question. So there are some risks associated with it. So as I mentioned, it does require hormonal stimulation. And so there are rare circumstances where that hormonal stimulation can cause side effects. And so you will be monitored very closely in that period. As far as the actual procedure for egg harvest, it is minimally invasive. And so there is not a waiting period from collecting eggs to actually being able to proceed with chemotherapy.
And I'm going to add a corollary to that. What about for the ovarian tissue or testicular tissue cryopreservation procedures, those surgical procedures? Is there a wait time after completion?
Yeah, so for testicular tissue, it does include a small incision through which the wedge of testicle is removed. And then for ovarian tissue, it's a laparoscopic procedure. So we're not expecting, a large abdominal incision, but rather a few very small incisions. And we do worry about wound healing once we start chemotherapy. That being said, we often start in the next 48 to 72 hours when patients require us to sort of move quickly. And the literature that's available does not show any significant side effects, in regards to having that procedure done and starting chemotherapy. What we always worry about, though, is wound healing and infection. So patients will be monitored very closely once they start treatment.
Excellent. Another question that came in is, how long is frozen sperm, I'm going to add, or eggs, how long are those frozen specimens viable and likely to produce a pregnancy?
Yeah, that's a really good question. A lot of families ask this as well. I'm not aware of a shelf life. I do know that patients, freeze eggs and sperm from their teenage years, anticipating to go back and 10, 20 plus years to use those tissues. So we don't have a concern about a short shelf life.
And along those lines, is there an increased risk for birth defects with stored eggs or sperm?
Not that I'm aware of.
Perfect. Is there an increased risk for birth defects for survivors who are now off therapy, but who were treated multiple times and may still be fertile?
That's a great question, too. No, we do not have any literature that suggests that there is an increased risk in cancer survivors to have children with birth defects or any specific medical conditions.
Certainly, it may be harder to have a viable pregnancy that goes to term,
yes,
but there is no evidence to suggest that a live-born baby would have birth defects associated with the cancer therapy that they received.
Exactly. Yes, exactly. And I think it's, to that point, it's always important to talk to your provider about your current medical condition. There are, long-term effects from chemotherapy. So, for example, if you have a heart condition related to your chemotherapy treatment, those sorts of things certainly need to be discussed prior to a pregnancy. But agree, Dr. Skiles, no increased risk for the babies.
Perfect. I'm just double checking our list of questions here. I think we might have covered all of them. We did touch maybe just a little bit on this topic. I'll just restate it in case we didn't fully answer the question. So do you recommend genetic testing for patients with unusual malignancies or a family history of cancers prior to reproducing?
Yeah, so Typically, when there's a cancer diagnosis and a patient has a very significant family history, in those cases, from an oncology perspective, we would often involve our medical genetics colleagues to sort of take a look at the type of cancer and the whole picture and determine whether or not we need to look into a hereditary or cancer predisposition syndrome. Outside of those scenarios, we would not routinely recommend genetic testing for patients with cancer.
Perfect. So one thing that I will just, as we're kind of wrapping up this session, one thing that we talked about, and I think one area of significant distress and frustration for both cancer survivors and those of us who do fertility preservation alike, is that we do see a lot of patients that did not have the opportunity to have these conversations on the front end and to be proactive about preserving fertility. We are working really hard to change that. But there are also a limited number of people that do this work. So I want to empower anybody that's listening to this, that if that conversation has not been had, it's okay for you to initiate questions about that and to ask for referrals accordingly. And even if you are done with therapy, it's also okay to advocate for yourself and ask for referrals. We try really hard to reach the patients that we can. Right now, both Dr. Saraf and I are pediatric oncologists, so that's where we spend the most of our time, but we are more than happy to help support and provide counseling for any patients even outside of Riley Hospital. It is our goal to help you reach your goals. So if we can do anything to help you in that, we are happy to do that. I'm going to state our contact information one more time. I don't know for our moderators that are behind the scenes if they can put this information up in a chat somehow, but I'm going to say it out loud as well. So our phone number is 317-944-0281. Once again, that's 317-944-0281. And the email address is fertility preservation, all one word, at iuhealth.org. Fertility preservation at iuhealth.org. So thank you so much, Dr. Sarah, for being with us today and being willing to answer all of these really important questions. And we are here and happy to help when you need us. So feel free to reach out.
Yes,
Thank you so much.